Great. That was Mandy. And the reason for hearing from Mandy is that she's just one of the many thousands of young people who have been through the MEND 7 to 13 programme. And I just wanted to remind everybody why we were here today, really, and why it's so important that we work with young people like Mandy and her parents to change behaviours around physical activity and food. Do you know what? She could have easily become one of the predicted 40% of people who, based on current trends, will be obese by 2025, but I guess you all knew that. The good news, however, is that by participating in a MEND programme, Molly's now returning to a healthy weight, and life's looking much better for her. Behind me are the four things that we want to talk about this morning, so I'm going to move on without further ado. I've been in this sector now for 12 months. I came in from sports development, and it strikes me that in the world of health and childhood obesity, we do like to talk about things. We'd really like to do a bit more research, consult more widely, hold a conference or 9. Things seem to be, you can't move for a conference. My inbox is full of them. But one thing I would say is how many more research papers do we really need to see before we take real and meaningful action? This slide, it highlights some of the recent research published around obesity and fitness. And do you know what? This one around babies of overweight mums run the risk of obesity. Didn't we know that already? I would say it's now time for action, and the real focus should really be on evidencing the things that really work, sharing best practice, and delivering the behaviour change programmes that local communities really need. All you've got to do is leaf through my favourite newspaper. No, it's not. The Sun. This is me coming at the Guardian at the end here. You know, obesity is the #1 health crisis, says the Sun. Obesity is now a bigger threat than smoking, says the Independent. By 2020, 80% of men will be overweight, study shows in the Guardian. So the headlines are all there. And I don't know if you saw BBC Breakfast last Friday, but there was talk of a children's clothes manufacturer reviewing the size of our current range of young people and then rethinking the range of sizes of clothes that they're stock in the future. Likewise, I was driving to a meeting in Highgate, and 5 Live were talking to a manufacturer of playgrounds, in particular slides, and the guy was talking about how he was making slides 6 centimetres wider. And whilst MEND applauds a really supportive approach to young people, because you wouldn't want to see young people squeezing into their clothes, would you? Or squeezing into a slide. Isn't the better approach to take more proactive action about using programmes like the MEND programme range to actually help these young people return to a healthy weight? And the last thing, there just seems to be so many strategies. This is a particularly good one. This is the London Health Inequality Strategy. And the most interesting thing about this strategy is that if you read Boris Johnson's foreword, he talks about average life expectancy reducing by a year for every tube stop passed from central London going east. And I'm a Leyton Orient fan, so and yeah, that's way east. So I'm getting worried already. So joking aside, it really is time for action. Just wanted to talk a little bit about the policy context, and I'll put commissioning at the bottom, and I'll tell you why in a second. We see opportunities and reason for optimism in the approach to public health that the new coalition government's taking, and also opportunities within the financial constraints within which it's operating. What I've done is put together a backdrop of the policy context against which we hope to deliver our MEND programme range. And we're wandering around a really nice cocktail of, is the legacy of the London Olympics combined with a focus on public health and addressing health inequalities, underpinned by a drive towards big society and taking greater personal responsibility, a combination to make a real difference? We'd like to think so. We'll put commissioning in for a reason. There's going to be a real need for providers like MEND to be innovative and extremely cost effective. But in return, we would ask commissioners to be more flexible, work with providers to work higher quality specifications, and above all else, think about working in collaboration. For example, if all the London Olympic boroughs were to jointly commission a behaviour change programme like MEND, just think of the savings that we could offer as a provider. What is an effective behaviour change intervention? It's a term that's widely bandied around, and here are 4 quotes from the Foresight report, the Conservative Party's Health Green Paper way back in January, it seems now, the Marmot Review, and the current consultation that's live with the Lord Science and Technology Select Committee. And I know what you're thinking, he has to get out a bit more. But at MEND, we believe that we can deliver cost-effective behaviour change interventions at scale. We provide the expertise that enables local health partnerships to reach their communities. And Harry's going to take you through just how we do that.
Afternoon. I'm afraid I don't have quite the same run-up and handy lines yet, but I got the very basic description of what we do, so I'll stick to it and try and rattle through it to give some time for questions at the end. MEN stands for mind, exercise, nutrition, do it. And the mind, the behavior change, the physical activity, and the nutrition education are the three different elements that you probably know need to be combined if you want to have a chance at creating sustainable weight management in children. And that's something which, despite that knowledge having been around for quite a long time and widespread evidence for it, there are still plenty of putative weight management programs that do not include those, which is interesting. And the bit that everyone often forgets, and we've been working hard on, because we didn't have it originally, is the do it part. It's not just understanding it, it's actually putting it into action at the end and continuing to do so. So the key elements underpinning what we do, everything we do is evidence-based and researched. We've got a randomized control trial. We have widespread national rollout data, range of peer-reviewed articles. The multi-component part I've talked about. The programs we work with, where we work with children, are all family-based, so you need to have a parent or carer. And they're developed by specialists in obesity, so that's psychologists, dietitians, physical activity experts, and also experts in various delivery channels for delivery by a wide range of non-specialists. That's to help. It doesn't mean that only non-specialists have to deliver it, but it helps on the cost-effectiveness side of things. What Phil was talking about is evidenced by if we were to do this on a large scale, for example, across through leisure centre delivery, we'd be able to get a 50% unit cost saving. That's an enormous cost saving, but it doesn't happen if it's done individual PCT by PCT. And they're community-centred, so it's about demedicalising the problem. Not to say you can't have health professionals involved in delivery, and there's very strong linkages with health professionals, but it's not about just making the problem medical. And the partnership working is critical. I think we'll all be talking about partnership working, whether it's local, whether it's regional, whether it's national. It's absolutely fundamental, and even more so in the new environment, and in the environment where the sort of economies of scale and cost effectiveness and value for money are fundamental. So we have a range of different programs. You can see the ones in the middle which have numbers. They're for ages of the kids. On the left-hand side, we're just piloting a postnatal weight management program, and on the left, we're doing an adult healthy lifestyle program under the Change for Life sub-brand, More Active for Life, with the Fitness Industry Association. Quickly, an example of one, the 7 to 13 program. It's for overweight and obese 7 to 13-year-olds, developed with Great Ormond Street and UCL. And as I mentioned, the family approach beforehand, groups of 10 to 15 families per program. It's 10 weeks of intensive program, 2 hours twice a week, so it's pretty full on, but then it has tapered support up to 2 years. So it's not just a 10-week program and then, good luck. That's not terribly helpful or supportive. It's a 10-week intense program to really focus on the behavior change, and then a sort of tailored, decreasing, tapered period of support. Just to bring it to life a little bit, you heard Molly earlier. Activity, land, water-based, multi-skills stuff, not so much the traditional sports. Basic nutrition targets, education, so everyone at the end of it, parents and children, know how to read food labels. And that's brought to life with some pretty high-impact demos, very simple stuff, but how much sugar and fat are in it, they have to match up the different product labels. And so when they see that there's 2 or 3 times the recommended daily amount of sugar, maximum amount of sugar for a kid of that age in a packet of Haribos, which can very easily disappear whilst watching TV in the evening, that really starts to bring the issue to life. And then made even more real, actually, by doing supermarket tours. Peer modelling is very important, and positive role modelling from parents. I talked about the maintenance side of things. The evidence, I could bore you for ages with this, but I won't. There's plenty of it. It's on our website, and we're very happy to give you more information if you're interested. What's important about this is that there's 3 blocks. Left-hand block is the start of the program, middle block is the end of the 10-week intervention, and the right-hand block is 3 months afterwards. And at the time, we had no follow-up support. And what you'll see is that the green block, which is the intervention as opposed to the blue control group, decreases. You'd hope things got better over a 10-week program, but then rather more interestingly, it continues to get better afterwards, because we're not trying to do a crash diet, we're trying to lay a foundation for healthy living, and they all become highly statistically significant, which is encouraging, and their results are maintained at 12 months.